everyone, welcome to Shannon, Veronica, and Everything. We are still struggling through the most boring subject ever, ortho. So we'll try to make it interesting. Today we'll be going over some fractures and stuff of the foot. So to start off with a simple toe fracture, this is if you break anything besides your great toe, you're fine. It's just going to be buddy tape for 3 to 6 weeks, reduce if you need to, and a hard shoe. Complex toe fracture, that is going to be if you break like a lot of toes, or if you break something through the articular space or interarticular break, or you break the big toe. Then you'll do 3 to 6 weeks buddy tape, hard shoe, and follow up with ortho in 3 days. So the exact same thing, it's just you need to do a 3 to 5 day follow up with ortho if it's not simple. If it's simple, don't send them to ortho. The professor said if you send a broken little toe to ortho, they're going to be like, what are you doing? So next thing is metatarsal fractures. So you can see here, we talked about the toes, so that's going to be the proximal and distal phalanx. Proximal, intermediate, distal phalanx, those are the toes, so phalangeal fractures. Moving on to metatarsal fractures, a little bit worse. So you can have a simple or complex. So simple would be a single fracture of one metatarsal or a stress fracture, whereas complex is going to be multiple fractures or fractures that are more than 3 to 4 millimeters displaced or 10 degrees of angulation. So the treatment he had written really well, but he said reduction for complex and then might require surgical fixation if you have multiple fractures. I don't know for single, I'm guessing it's just like the boob too. So that was kind of vague in his lecture. But we do have a couple metatarsal fractures that you have to watch out for. So a second fracture is a Liz Frank, very dangerous. And then a fifth fracture, there's 2 types, it's Dancer's and Jones, with Dancer's or avulsion fracture being more proximal and Jones fracture being a little bit more distal. So we're going to start with Jones fracture. It's a little bit more distal, so it's kind of on the base but not quite as proximal as the Dancer's of the 5th metatarsal. So this can extend into the 4th, 5th intermetatarsal facet, so into here. You can do non-weight bearing short leg cast for 6 to 8 weeks and an ortho referral. So just remember, Jones is worse than Dancer's, non-weight bearing 2 months. And then the Dancer's or avulsion fracture of the 5th metatarsal, you're going to hear sharp pop at dance class, and then this is going to be short leg cast, weight bearing for 4 to 6 weeks. So then we have our Liz Frank fracture. This is going to be your 2nd metatarsal break right here. For this one, you're going to have midfoot pain and then ecchymosis. You'll have some bruising. The treatment is going to be an ORF and careful of compartment syndrome. And then a calcaneal or heel fracture. This is called the lover's fracture because you jump out the window if you're crouching against someone. So one thing to note with this is check for spine fractures also from the jumping out the window. And then the way they check this is by looking at the bowler's angle. It's like the heel angle. If it's less than 20 degrees, you probably have a calcaneal fracture. Treatment exact same as a 2nd metatarsal Liz Frank fracture, ORF, and careful of compartment syndrome.
Alright everyone, I'm going to go over our non-fractures of the foot. So to begin with, we went over onchokeratosis, but we should already know that's just an ingrown toenail, so we need to review that with this. We then have a Morton neuroma. So this is going to be a mass that the patient typically is going to feel to begin with, and then you're going to bring it into you, and you're going to feel that there is a mass underneath on the foot. Classically, it's going to be between the 3rd and 4th metatarsal heads. The cause, we want to say it's shoes, but I don't think that's kind of been confirmed. But that's kind of the most likely cause. So as far as treatment, we're going to just recommend that they get some new shoes. They can use NSAIDs for pain. If that doesn't work, you can then do an ultrasound guided injection, and they're going to be using a neurosclerosing agent to just kind of kill off that nerve. We then have plantar fasciitis. This is super common. I'm sure everyone will see this in clinic. The biggest thing is going to be that somebody says that the pain is worse right when they wake up in the morning when they take that first step. And it's just a micro trauma with inflammation of the plantar fasciitis or fascia. And as far as risk factors, so somebody who's obese will be at risk for this, or somebody who's doing prolonged standing, so for their job, maybe they have to stand at the register all day or something. As far as treatment, NSAIDs for the pain, icing, do some stretching, they can use orthotics, corticosteroid injection, and then the last resort will be surgery for this. We then have our hallux valgus, also known as a bunion. This is a medial deviation of the 1st metatarsal. So if these are your feet, the toes are going to be kind of going like this. You kind of have this bump that forms here. As far as treatment, you want to change your footwear, NSAIDs for any pain, orthotics orthodontics surgery if you find that it's painful for any type of range of motion or there's inhibition of activity for your patients. So thanks for tuning in. Don't forget to like and subscribe to our channel.